This is Amanda Bullard, doctoral nursing practice student at Jacksonville State University. This is the X-Treme Makeover video for NU713 Organizational and Systems Leadership for the Advanced Practice Nurse. We're going to discuss an introduction, learning outcomes, a miscommunication in the workplace, how that affected the culture of the facility and the staff, and how we could possibly reflect and change that based on some better communication techniques. So the purpose is to discuss an instance of miscommunication at a substance abuse treatment center and propose changes in communication which could have positively affected the outcome. The organizational mission, vision, and values are to assist every individual suffering from addiction to obtain the treatment needed to live a life free from substance abuse, and promote a place of employment which empowers staff members to excel in their positions and provide superb patient care. The future organizational goals include a culture of transparency, a team of empowered individuals, clear communication with patients and staff, and supporting one another while delivering excellent care to substance abuse clients. Challenges in obtaining this include employees or departments which are opposed to change, lack of leadership in some departments, and staff perception of lack of support from administration. Our learning outcomes include understanding how miscommunications in the workplace can affect patient care and how improved communication and active listening can positively impact facility culture and the patient experience. So this miscommunication actually occurred between nursing staff and a substance abuse client. This example that we're going to give today. So a patient that has been established as non-compliant was coming for meds on time. Meaning that his assigned med time is a specific time, but he always comes outside of that time for whatever reason. So he's non-compliant with the rules. He presented to the medical unit 45 minutes early for his meds because he needed a PRN medication to treat a symptom that he currently had. This happened to be in the middle of the med nurse's end of shift count, which means that the medication machines were not available to be pulled from. The charge nurse noticed the end of shift count in progress and notified the patient that he could get meds in about 5 minutes. She was currently engrossed in prioritizing emergency transport for an acutely ill patient and did not look at the patient in the eye when she spoke to him, nor look up in any manner to give him any sort of her attention. She also did not explain to him why he could not have his medications at this moment and needed to wait a few minutes. The patient had been threatening to leave AMA for several days, and this made him even more upset when she told him he had to wait without giving a response of why or paying any attention to him. A newly hired staff member saw the interaction, saw that there was some friction, and tried to lighten the mood by jokingly stating, "You can wait 5 minutes, can't you, honey?" The patient was not receptive to the joke and stormed off the unit, very upset because he felt disrespected, condescended, and brushed off. He was able to process this interaction with his group that evening and decided to stay in treatment long enough to meet with the director of nursing the following morning to discuss his concerns. So how did this happen? This occurred because the patient, who had not been compliant with assigned medication time since being admitted, was once again presenting to the medical unit requesting medications outside of his assigned time. He felt justified in doing so because he was experiencing a symptom at the moment that required medication in order to improve. The charge nurse, who had been extremely busy with an acutely ill patient, was focused on her priority patient when she responded coldly and abruptly to the patient presenting for a PRN med. She did not take his perception into consideration in providing her answer. So she didn't consider how he would feel about her continuing to work on this priority when he just needed a moment of her time. The staff member who witnessed the encounter misread the patient's nonverbal cues and jokingly made a statement that the patient perceived as condescending and disrespectful. The variables of influence include the patient's established noncompliance, unstable pre-admission patient requiring immediate transport, which is the emergency transportation that the charge nurse was working on, several consecutive days of unstable patients presenting for admission, which consumed much of the staff nurse's time and efforts throughout their shift, leaving little time for patients already admitted, higher acuity admissions resulting in staff emotional exhaustion. We also had a flu epidemic resulting in call-ins, overtime, sick staff members, and then new staff members with limited motivational interviewing training attempting to help the situation, which inadvertently worsened the situation. So all of these factors influenced the fact that the patient had an interaction with the nurse that left him feeling unvalidated and disrespected. So what were the conversations surrounding it? Obviously, the patient was very upset. He was sharing this with his group because that's how he processed. He was explaining his frustration with the staff to the group members, which then allowed them feedback, and the negativity sort of went from there in regards to patient perception of the nurses. In regards to, that's the themes of conversation among the patients. Among the nurses who are more concerned with this higher acuity, not higher staffing ratio, focused on staffing and the concerns regarding patient acuity and patient safety, but not feeling like those concerns were validated or understood. There was frustration from the medical staff to the clinical staff. So nurses were frustrated with clinical because they weren't reinforcing the rules regarding patients coming to meds outside of their scheduled time. So while patients were permitted to come outside of their time if necessary, they had to have approval from their clinical staff, and clinical staff had to communicate this to nursing staff. This was consistently not being done, resulting in patients presenting to the medical unit without communication from clinical, which allowed the nurses to be under the assumption that the patient was just non-compliant with rules, when perhaps they had been told by clinical they could come, but that was not relayed to medical. So there was some frustration between nursing and clinical as well. There was burnout related to working with substance abuse patient population. This is a common thing of the non-compliance, and a lot of times these patients may make you feel as though nothing is ever good enough and nothing is ever going to change. So while the nature of the disease is that it's relapsing, remitting, and so seeing the same patients over and over, or having the kind of seeing the same patterns from the same patients day in and day out can really wear emotionally on someone working with that every day. Culture is generally formed by four things: determining human nature, which is beliefs about how employees, customers, and suppliers should interact and be managed. Next, organizational relationship to environment, which is how does the organization define business and constituencies. Third, appropriate emotions, which indicates what emotions are encouraged to express versus which emotions are encouraged to suppress. And then effectiveness, how are we measuring the facility's success? How do we know it's successful? Culture is manifested in many ways, including leadership behaviors, communication styles, internal memos, and corporate celebrations. The culture of the nursing staff during this incident was one of defeat, separation, every man for himself, and hopeless for improvement. The nurses felt overworked, underappreciated, and devalued. Likewise, the patient felt essentially the same way. He was not appreciated, he was devalued, and he felt condescended and disrespected. And that in turn set the tone for his interaction with all nurses in the future, as they would present later on. So organization is conversation. Essentially, this is a complexive response process. It's co-created, meaning we work on the change together. It's a relational system. Leadership is relationship driven and involved in day-to-day interaction. So it's a culture of brainstorming, working together to achieve a common goal. For example, in this miscommunication example listed, the charge nurse could have been transparent with the patient and explained the reasoning for the short wait for meds. So she could have taken just a second from what she was doing, looked up, gave the patient her undivided attention, and said, the machines are currently inaccessible, but they will be back in 5 minutes. Additionally, had she given him some of her time, just a little bit of her time and her attention, the patient would have felt validated in his request because she looked up, she gave him verbal and nonverbal cues. This would have built rapport between the patient and the charge nurse, which also could have, again, trickled down into his interactions with other nurses. As far as the nurse culture in the facility, nurse and clinical working together, nurse and administration working together, all brainstorming together to resolve the issue of the increased acuity but not increased staffing, could have greatly improved the nurses' demeanor, and they could have felt like they were being heard and like their issues were validated, and that could have helped to improve morale. So patterns of relating are how people interact with each other, how it forms an organization's culture. It includes things like preferred communication methods and habits exhibited during tasks like meetings. So taking the time By focusing on the task at hand and not taking the time to relate to the patient, the charge nurse made the patient feel like a nuisance, not worthy of her time. While this was definitely not her intention, it did set the tone for all of this patient's interactions with other nurses. It also established the culture between this patient and the nursing staff, and as he's processing that in group, it plants the seed of this in all of the other patients that are going to present to the medical unit to see a nurse. Likewise, when the nurses voiced concerns regarding patient acuity without increased staffing, it was met with indifference and lack of discussion or brainstorming for change at the time. Had administration at least given the nurses a time where they could sit down and talk with them and maybe discuss methods that they could improve the situation, then they could have felt validated as well. So patterns of meaning inform the collective organizational identity. They might be financially driven, might be patient safety driven. So organizations, specific themes that exist in the organization inform that collective identity. And if you're driven by mission, vision, and values, you're gonna have a very much different influence on staff than organizations that are driven by fiscal responsibility and profit. So in the example given, the patient was made to feel like just another number. The charge nurse was made to feel like the organization was more concerned with filling beds than patient care. So it had more of a financially or fiscally driven pattern of meaning to it in this instance, even though that was not the intention. So ways that they could have improved that would have been to, like I said, had a conversation with them. The charge nurse could have had verbal and nonverbal conversation with the patient, explained everything in depth, or even had the clinical staff called down to the unit, then that charge nurse could have assigned the task of dealing or handling this patient's request to a specific staff member, and then that could have also helped the situation. So ways of talking, listening, and being. Talking are patterns that reinforce and stabilize culture and introduce new language habits. So we have to remain aware of the words that are being said and how they're being said. So in our example, the nurse was too busy to be aware of how she informed the patient that it would be a few minutes before he could have his medication. The new employee made a joking comment in a tone of voice that was interpreted as disrespectful and condescending, even though that was not her intent. These interactions reinforced to the patient that the nurses were unprofessional and could not be trusted to provide care. So that is his perception of the nursing staff. Had the charge nurse listened carefully to the patient's request, she could have provided appropriate feedback to him. Additionally, administration could have been willing to actively listen to nursing staff, then it could have established an improved rapport with nursing. Mindfulness is being aware or awake, present moment to moment. It's an excellent means of participating and contributing to the organization as a conversation, just being mindful of what's going on. Additionally, innovation is enabled by both and thinking, and it's restricted by either or thinking. So everyone has the ability to build his own capacity for innovation, and it's best fostered by leadership supporting shared ideas. So again, going back to everyone's working together, everyone's sharing the responsibility of coming up with the action plan. So how could this be done differently? How can we reflect and rewrite? How could it all be different? Patients participating in the program inform the clinical staff that he needs to go to the medical unit for a PRN medication. The clinical staff then phone down to the unit to inform them of the patient's need to come for a med outside of med time. The charge nurse, who is busy with an acutely ill patient, assigns the task to another nurse who is to meet the patient upon his arrival from the cottage. The nurse speaks to the patient politely, professionally, listens to his concerns and complaints. So since the med nurses are completing an end-of-shift count, the nurse tells the patient it will be about 5 minutes, but she will bring the PRN medication to him in the vital sign booth as soon as possible. As soon as possible, the nurse obtains the medication, brings it, and gives it to the patient. The nurse then reviews the rules regarding medication pass with the patient, and he verbalizes understanding. The charge nurse stabilizes the acutely ill patient and then performs a literature review to determine potential solutions for her concerns regarding unsafe environment due to high acuity patients without additional staffing. A staff meeting is called to discuss these issues, and all communication and suggestions are encouraged. This is a way that the situation could have been handled much differently and come out to a better outcome for both the patient and the nursing staff.